Good evening, and thank you everyone for being here with us today. I, Amit Saxena, along with my teammates from Jagsonpal Pharmaceuticals Ltd, Dr. Deepika Chabra, Mr. Arvind Singh from Medical Services, Ms. Ragini Sati, Brand Manager, DIVATRONE, and Mr. Vinod Upadhyay, Zone, based at Varanasi, are delighted to welcome you all to Scientific Sangam, organized by ISOPARB Prayagraj, in association with Baroda and Gorakhpur Obs and Gynae Society. The academic program partner for the program is Jagsonpal Pharmaceutical Ltd, makers of the most economical brand of Dydrogesterone 10 milligram tablet, DIVATRONE, fully indigenized and micronized, the only brand having 36 months shelf life. Our excellent product include maintained injection 250 and 500 milligram depot 17 alpha hydroxyprogesterone and lycorate preg sachet of L-arginine, lycopene and DHA. We thank ICOG for granting 2 ICOG credit point to all the attendees of this webinar. We extend a warm welcome to all the esteemed faculty and attendees. Dear attendees, if you have any questions, suggestions, clarifications, please post it on the Q&A box. Please note this webinar is streaming live on Facebook and the chat has already been shared in the chat box. We thank the organizing chairperson, Dr. Ranjana Khanna, Founder President, ISOPARB Prayagraj, and Organizing Secretary, Dr. Amita, Tripathi, Secretary, ISOPARB Prayagraj, for taking Jagsonpal as academic partner for the scientific sangam. Now requesting Dr. Ranjana Khanna ma'am to kindly initiate the proceedings.
A very good evening, everyone. And at the outset, as everyone knows, before we begin our scientific programs, we start by remembering Lord Shiva. Welcome everyone. I take this opportunity to invite everyone present here, the faculty as well as the delegates, for our National FOGSI conference which has been given to us. And the Allahabad Society is really excited and working hard over the conference. It's on obstetric dilemmas on 6th and 7th August. And we have a very nice venue this time. We have our AMACC Convention Center. It's a beautiful convention center. And I'm sure all of you are going to enjoy not only the scientific extravaganza, but also our warm hospitality and the mouth-watering delicacies as well. So welcome everyone. And now I would like to invite our chief guest, Dr. Hrishikesh Pai. Has he come?
Yes.
Madam, sorry.
Dr. Hrishikesh Pai, as everyone knows, is an iconic figure of FOGSI. And he has done so much work for FOGSI, not only FOGSI, for every individual FOGSIan. I feel that, you know, I really think that he is one of the most helpful persons we can think of. And of course, everyone knows that he is the president-elect of FOGSI. And after Dr. Shanta, he'll be taking over as FOGSI president. And presently, he is the medical director, Bloom IVF Group. He is the administrator of FOGSI Manyata Initiative. He is director, corporate affairs, IFFS, International Federation of Fertility Societies, adjunct assistant professor at Eastern Virginia Medical School, USA, postgraduate teacher in Gynae at DNB examinations in India, visiting professor in Obs and Gynae, Manipal University, and of course, his interest, everybody knows, is infertility, endoscopy, IVF, ICSI, egg freezing, and genetics. I think he is way ahead of his times and always keeps updated about his knowledge in IVF. Major achievements are awarded with the esteemed fellowship of the, of course, of RCOG, Obstetricians and Gynecologists of London, past Secretary General, Senior Vice President, Deputy Secretary General. Arey, to Hrishikesh, this is a very nice opportunity for me to spell out all that you've been doing. And of course, he has delivered so many orations. And besides that, he is an editor of 16 plus books. And he is editor, Indian edition of British Journal of OBGYN. Numerous research publications to his credit. We welcome you, Hrishikesh, to this webinar, and which has been hosted by ISOPARB Prayagraj in association with Baroda and Gorakhpur societies. And before you give us your blessings, I would like to invite you to our National FOGSI conference at Allahabad. That is on 6th and 7th of August. And I'm sure that you must block your dates, Hrishikesh, and don't say that, no, I was busy there, and then you and Rishma have to come. So
thank you, madam, for actually inviting me. You're our favorite. You are one of the dynamic vice presidents of FOGSI before. And, you know, I always say that many people are capable of becoming the presidents of FOGSI, and you are one of them, which just that it's a pyramid. So in
thank
the
you so
pyramid,
much.
some people can't, but that doesn't mean that you are all equally capable. And, you know, anyone in my place or anyone else's place would have perform equally well, and that is the greatness of our federation, that many people are highly competent, and
Yes.
they are all committed to the federation. And I can see that a lot of people, a lot of my friends are here. Would like the Baroda Society, the Allahabad Society, and the, I think the third society is
Gorakhpur.
the Gorakhpur Society. And I can see many of my colleagues, and Dr. Chitra Pandey is there, Dr. Umesh Shah, Dr. Amita Tripathi, Dr. Manisha Gupta, Archana Devedi is there from Baroda, Abhilasha Kumar, Dr. Preeti Niranjan, Parul Khanna, of course, the young upcoming. One day she'll become a chair and ultimately a vice president. Babita Shukla, Parag Biniwale, our dynamic president of the Pune Society. One day also, we are hoping that he will also ascend the ladder to the ultimate. Amrita Jaipur, and many others are there. I cannot take all the names, and I'm sorry if I can't. So this is a fantastic trauma during labor. Because of that I never practiced labor, because I was so scared of delivery when my president days. You know, because you know labor is one aspect where you can never know and predict what will
Yeah.
happen. So you know, many people say about IVF, and I say IVF and endoscopy are very controlled. Labor is not. The most skillful part of our profession is the labor and delivery. I mean, those who can handle labor and delivery means before that, IVF is nothing in front of all that labor and delivery. According to me, I can never, like, you know, though I've done a lot in my younger days, but I could never, you know, be comfortable in labor. And, you know, any time of the night, any moment, one moment patient is okay and suddenly there is a problem. So this is a big issue, and I hope that we can work on it. And as I was saying, that ISOPARB is a very important. The other day I called it as younger sibling, but equal sibling, I should say. ISOPARB is the equal sibling of the FOGSI, and you know we are all brothers and sisters. The various organizations like ISOPARB, ISPAD, IAG, IMS, ISAR, IFS. All of them are in different specialties, and we all are in that, and we are all brothers and sisters, and let's hope that we can together take the movement of forward. So you know, the next year my slogan is simple slogan. It is a healthy woman, happy woman. You know, if a
Wow.
woman is healthy, she is a happy person. So
That's
that
nice. That's
very, you know,
really good.
swastha nari sukhi nari. You know, it's a
Oh,
simple.
good, good,
And
good.
and the secondary slogan is modern technologies, you know, transform lives. Technologies help us to transform lives faster, better, quicker, and more effectively. And we must use the technology to do the revolution. And if you look at the National Family Health Survey number 5, it's a very exciting survey. Actually, about a week back, someone, Economic Times, phoned me. I thought I was very excited. I told Rishma, Economic Times has phoned me, and you know, it turned out to be Economic Times Hindi. So I was having a real tough time talking in Hindi to them suddenly, because I thought it's an English economic norm. But so I read the national survey thoroughly, because they wanted to interview me, and it's a revelation. So National Health Survey is number 5, is based on a survey of 630,000 households, and there's 17 agencies participated in this survey, and about 7 lakh women and 1 lakh men were interviewed. So it's a little lopsided survey, but there was a lot of progress. Our net reproductive rate has gone to 2. From 2.2, it has gone to 2. 5 states, including Bihar and UP, are about 2. But in order for a country to survive well in the future, 40, 50 years down the line, we must have a reproductive rate of 2.1. So we are at 2, so we should not go down below 2. So we must try to keep a balance. And if you look at the Kerala state, they have risen from 1.6 to 1.8. So slightly there is an increase in Kerala. Kerala was extremely down, 1.6. So they have come up because with the education, people don't want to have children. So that's a very important. And the first time the survey analyzed the incidence of anemia in the population, the incidence of blood pressure, incidence of diabetes. So NCDs is a very important, and one of the main campaigns of mine next year is called a Badlao campaign. My campaign, just like Dr. Shanta Kumari has a very important campaign called Dhira, and it's very important campaign for our FOGSI. My campaign is Badlao. So it's a campaign focused on the NCDs. So the 5 important NCDs are important for us. That is, we have anemia, obviously, blood pressure, diabetes, cancer, and the endocrinology, which will be made up of vitamin D deficiency, thyroid deficiency, and obesity. So these are the NCDs. Of course, cancer is also part of it. So these are the important, because our practice, so we have a dichotomous practice. One is based in the government hospitals, teaching hospitals, which is very important practice, but that's more based with, more of infections and this and that. So while the other practice, the private practice, is more based on NCDs. So we must focus on the NCDs in a very big way in the next, like next year. And of course, we will continue all our programs, like Dhira will be continued. And our incoming president, his favorite topic is abortion. So we will. So because I believe in integration and continuity. So we must become integrated and we must be continuous in what we do. We should not do sporadic thing. We should do a continuous thing. So anyway, I will stop here because otherwise I can take a lot of time. But I would like to wish you the very best. And, I want you to, let me tell you, anyone who wants to do something, you just have to come and ask. I'm just like, I don't want to be dramatic, but the fact of the matter is I'm just a saver. You have to do. FOGSI is a base for anyone to come, and whatever they want to do for the community and the society, they can do it. There's nothing, many people say that, oh, there is FOGSI doesn't know. FOGSI is an open organization. Anyone can do. And another thing I would like to tell you, FOGSI is an individual based organization. It is not we don't like to have groupism, Every individual who has got capability can achieve the top. That is the best thing about this organization, and we must maintain that individuality of our organization. Thank you very much for inviting me, madam, and I apologize for being a little slightly delayed.
You were quite on time. Actually, you were dot on time.
Thank you. Thank you. Dr. Verma, Manju Verma is also there, I think, So,
yeah. Dr. Hrishikesh, I would like you personally on my behalf to congratulate Rishma also. Because she's been she's another big achiever we have.
Yeah. And actually, Dr. Ranjana, I was trying to patao Rishma. I said, please, you do all the work in my ear so that I can have a good time. You do all the Gada Majuri. Anyway, thank you.
We had a lovely time in 2017, and I always remember both of you very fondly.
So we are hoping that Allahabad Society also does some FOGSI program next year. We are looking forward. I'll give you the program is made, but there are 11 main conferences, but there are 52 weekends. So you can take any weekend.
Yeah, give us
My only
also
request
one.
is that see that you don't clash, have a program in the same zone.
Yeah.
At the same
give
time.
us also one, Rishi, give us also one.
Yeah, we are always welcome. I love UP. I am in love with UP, Bihar. They are my favorite places. Gujarat also. हमारे मोदी जी का प्रांत है वो. So, Thank you.
Thank you so much, Dr. Rishi, for coming, for joining and giving us your words of wisdom and your vision for your presidential year. Thank you so much. And now I would like Dr. Abhilasha Kumar to take over.
Thank you, Dr. Ranjana ma'am, and a very good evening to our respected and distinguished chief guests, esteemed chairpersons, eminent speakers, and valuable delegates. The first topic for today's webinar is prediction and prevention of perineal tear. And for this, I would like to invite two renowned gynecologists, Dr. Manisha Gupta ma'am and Dr. Preeti Niranjan ma'am, to chair the session. Dr. Manisha Gupta ma'am is a retired as Superintendent in Chief of District Women Hospital, Allahabad in October 2020. She has more than 30 years of experience of working as gynecologist, administrator in PHMS, catering to underprivileged sections of society in rural and urban hospitals of Uttar Pradesh. She has done advanced laparoscopic training at AIIMS, New Delhi. She has teaching experience as counselor of IGNU and master trainer of PMHS for laparoscopic sterilization. I welcome you, ma'am. And I also welcome Dr. Preeti Niranjan ma'am, who is a senior gynecologist, senior consultant. She is the past president of Baroda Obs and Gynae Society. In her tenure, the society received Best Society Rotating Presidential Trophy. She is the past president of Vadodara Menopause Society. She has been credentialated as IMS menopause practitioner. Her special interests include adolescent gynecology and menopause. Welcome, Dr. Preeti ma'am, and I would request you to kindly introduce the topic and our eloquent speaker, Dr. Amita.
Thank you very much. Our next speaker, first speaker is Dr. Amita Shah. She is our current president of Baroda OG Society. I will like to mention her one quality, that she has got a good organizing capability and she can be a very good HRM. And I found her to be a good organizing skill. So we will see how whole year passes with her presidentship. And her topic of subject is prevention and prediction of perineal tear. And I'm 100% sure that in our young days, we used to get a lot of scolding from our teachers if there used to be any type of perineal tear. They used to feel that we had not taken proper care of the patient, and Dr. Amita will elaborate the topic very well. Now, I hand over the mic to Dr. Amita.
Thank you, Preeti ma'am, for the very kind words. I am very thankful to organizing chairperson, Dr. Ranjana Khanna ma'am, the founder president of ISOPARB Prayagraj, and her entire team for providing the opportunity to Baroda Obstetrics and Gynaecology Society to be associated with. With warm regards and gratitude from BOGS, I shall start my talk. Today's my topic is the predisposing factors and prevention of perineal tear. Perineal trauma. It is an extremely common and expected complications of vaginal birth. Lacerations can occur spontaneously or iatrogenically, as with an episiotomy on the perineum, cervix, vagina, and vulva. They can have significant impact on women by impairing their quality of life in both the short and long term. Clinical significance. The perineal trauma can have long-term effects on a woman's life and well-being, like psychological trauma, social isolation, pelvic floor dysfunction, pain, dyspareunia, and embarrassment. Incidence. More than 85% of the female undergoing vaginal delivery will suffer from some degree of perineal tear, one or at some other time. 0.6 to 11% of all vaginal delivery results in a third or fourth degree tear. Incidence of perineal trauma is 90.4% in nulliparous women and 68.8% in multiparous women. So, with a subsequent birth, the risk of perineal trauma decreases. We will just have the gross look at the gross anatomy. The pelvic floor is a muscular diaphragm that separates the pelvic cavity above from the perineal space below. It is formed by the levatorinae and coccygeus muscles and is covered by the parietal fascia. This is the muscular of the pelvic floor. urogenital diaphragm. It is external to the pelvic diaphragm and includes the triangular area between the ischial tuberosities and the symphysis. It is made up of deep transverse perineal muscles, sphincter urethrae, and internal and external fascial coverings. Perineum. It is a diamond-shaped space that lies below the pelvic floor. Perineum. It is bounded by superiorly by the pelvic floor, laterally by the pelvic outlet consisting of subpubic angle, ischiopubic rami, ischial tuberosities, sacrotuberous ligament, and coccyx. Inferiorly by the skin and fascia. The area is divided into two triangles by transverse muscles of the perineum and base of urogenital diaphragm. Anteriorly, it is known as urogenital triangle, and posteriorly, it is known as anal triangle. Most of the support is provided by the pelvic and urogenital diaphragm. Perineal body, which is the most important and related to our talk today. The perineal body, the central tendon of the perineum, is the pyramidal mass of tissues about 4 by 4 centimeter. The median raphe of levator ani between the anus and vagina is reinforced by the central tendon of the perineum. Bulbocavernosus, superficial and deep transverse perineal muscles, and anal sphincter also converge on the central tendon. The muscle contribute to the perineal body, which provides the much support to the perineal body. Now, the classification of the perineal tear and obstetric and anal sphincter injuries, OSCs, will be taken by my another next speaker. So I will just pass on to these slides. Risk factors for the perineal tear. The maternal risk factors are nulliparity, increased maternal age, Asian ethnicity, vaginal birth after cesarean section, less than 20 years of age, and shortened perineal length, that is less than 25 mm. Coming to the fetal risk factors, large fetal weight more than 4 kg, abnormal position of the head, which is most commonly the occipital posterior and face presentation, shoulder dystocia, breech delivery. Intrapartum risk factors, which are mainly responsible for all the perineal tears, the instrumental delivery like forceps and vacuum, prolonged second stage of the labor, that is more than 60 minutes, epidural use, oxytocin use, midline episiotomy, precipitate, uncontrolled, or unattended delivery, which is the most frequent cause, and patient's inability to stop bearing down, hastening the delivery by excessive fundal pressure, edema and friability of the perineum, vulvar varicosities, weakening the tissue, and narrow pubic angle with outlet contraction, forcing the head posteriorly, and extension of episiotomy, which are responsible for the intrapartum risk factors. There are some non-obstetric injuries which may cause the perineal tear, like rape or molestation, falls, accidental injuries like road traffic accident, bullhorn injuries. Now, coming to the prevention of the perineal tear, first of all, we have to identify the woman at risk and avoidance of unnecessary obstetric intervention. Maintain the woman in the left lateral position till active pushing, timely episiotomy when indicated, and warm compresses to the perineum during the second stage. Intrapartum perineal massage with lubricant, and mother is advised not to push when the head is crowning. Support to the perineum during crowning and expulsion. Now let us see these preventive measures little bit in detail. And controlled delivery of the head. Episiotomy. The aim is to increase the diameter of the vaginal outlet to facilitate the passage of the fetal head and to prevent the vaginal tear. Though it is said that episiotomy prevents the OSCs and or anal incontinence, but still it is controversial. The indications of episiotomy will be instrumental delivery, breech or breech extraction, rigid perineum, past history of perineal tear, high probability of 3rd and 4th degree perineal tear, and soft tissue dystocia, or to accelerate the delivery in compromised fetus. Technique. The angle of incision recommended for mediolateral episiotomy is 60 degree. Spatial scissor design to ensure 60 degree incision is effective. A scar angle of at least 45 degree measured in relation to the midline after suturing is associated with a lower risk of perineal injury. So the resultant suture angle of 40 to 60 degree is more important than the incision angle of 45 to 60 degree. The second stage of labor, the attention should be paid not to the perineum, but to the controlled delivery of the head. Aim is for more control and less expulsive pushing. Delivery by early extension is to be avoided. Flexion of the subocciput comes under the symphysis pubis so that the lesser suboccipitofrontal, that is 10 centimeter, emerges out of the introitus. Suboccipitofrontal 10 centimeter diameter. Spontaneous forcible delivery of the head to be avoided and not to bear down during the contraction. To deliver the head in between the contraction, to perform timely episiotomy when indicated, and to take care during the shoulder delivery is the wider biacromial diameter, that is 12 centimeter, emerges out of the introitus, and Ritgen's maneuver, that is assisted delivery of the head by extension, exerting an upward pressure to the chin by the right hand placed between the maternal anus and complex. Ritgen's maneuver, usually not much practiced. Another factors related to prevention are the warm compresses, if it is applied on the perineum during and between the contraction, reduces the risk of 3rd and 4th degree tear. Perineum massage, if done during antenatal period and in second stage of labor, may reduce the chances of perineal tear. Now, recommendation for the subsequent deliveries for the prevention. Suppose the patient has passed through the major degree of perineal tear in the previous pregnancy, the patient should be counseled about the developing anal incontinence or worsening the symptoms with subsequent vaginal delivery. If the perineal tear has occurred, it is to be documented as far as the type of the tear, method by which it was sutured, and the suture material used. Any patient having OSCs in previous pregnancy and who are symptomatic or have abnormal endoanal USG should be counseled regarding option of elective LSCS. The take-home message will be: the start perineal massage at 36 weeks, alleviate the fear and anxiety, felicitate the occiput anterior presentations, eliminate the midline episiotomy, place a warm compress in the late second stage, adduct the thigh as a delivery, position 90 degree or less, straighten the legs at delivery, position 90 degree or less, support the perineum, that is hands-on, aim for lateral episiotomy if indicated, go slow, control the head, deliver after contraction, excel at the operative delivery, and last, the superb repair technique. At the last note of my talk, I would like to end with this comment that formal training in anal sphincter repair techniques should be an essential component of obstetric training to avoid the long-term complications. Thank you. Thank you all.
Very nice talk, Dr. Amita.
Thank you, ma'am. Thank you. Thank you.
Good evening, respected seniors and my dear friends. First, I would like to thank you, the organizing team, to include me in this wonderful session. And thank you, Dr. Anita, for giving such a wonderful talk, covering all the anatomy, physiology, predisposing factors and preventing factors, and the future impact of the previous trauma.
Yes. Thank you, madam.
There are few things regarding predisposing factors. Like age of the patient is very important. Young primary with tight perineum, number one. undiagnosed malpresentation, malposition, and size of the baby. Next is obstructed labor, not giving proper perineal support, previous scarring of the perineum where any surgery has been done, and the unskilled delivering staff. Staff should be very expert and skilled while delivering the baby. These are the few points we have to kept in our mind for the predisposing of the trauma, perineal trauma. And for the prevention, we have to identify the predisposing factors, keeping in mind. So first of all, there should be preparedness of the place and person. Place means where the vaginal delivery is going to take place. Availability of the logistic, medicines, working condition of the instrument, ventues, forceps. And about the patient as such, she should have been counseled during NC period, during labor for the cooperation and support. And the next person is doctor or the supporting staff or who is going to deliver the baby. It might be a senior nurse or the junior doctor or the senior doctor, whosoever maybe, they should be very skilled. So after the preparedness of the place, there is prior diagnosis of the presentation, malpresentation, prior diagnosis of the position, size of the baby, more than 4 kilograms. Any history of previous pelvic surgery, inappropriate use of oxytocin has to be avoided. And then there should be strict and very rigorous training of the resident doctors or the staff delivering the baby, or if senior doctor is not very well versed in the forceps and vacuum, they should avoid it. So training program is very important. So lastly, the training for the repair of the pelvic injury, if any, that is very important. There is also one word which is very common and popular. Our government is also very sensitive about respectful mother care. That is, every pregnant woman has a right to be safely delivered in a pleasant place. And there should be availability of a very familiar or supportive attendant all the time. That attendant is very helpful to the patient and the delivery staff also, because many times he warns us about the warning sign or symptoms patient is having if there is any scarcity of the staff. If there is patient is going into precipitate labor, she has to warn the staff. So respectful mother care is very important. We all have to support the patient in a very congenial atmosphere. We have to identify any warning sign that I have already told, and there is the future, and there is one word about the future impact. Fear for the future vaginal delivery. That is very important. Laxity of the vagina and sometimes prolapse of the cervix and uterus. So if we diagnose the predisposing factors, perineal trauma automatically will be prevented. That's all. Thank you.
Thank you, madam. Very nicely summarized. Very nicely summarized.
Madam, I wanted to just make a few points before I leave. So one was that our Manyata program, no. Just now we had a meeting in Delhi with the NABH people. So NABH is going to come in and join the Manyata program. And so NABH has a certification, because if you get a NABH certification now for your hospital, then there's a lot of advantages. The government gives you a lot of insurance covers, etc. So the Manyata, we are in the process of final negotiation where so the 16 standards of Manyata will help you to get your hospital at a good level, and more people will start coming to your center. So it's a good marketing for the future. Secondly, the same standard, the NABH training will be given so that you can apply for what is known as entry-level NABH. So once you get the entry-level NABH, all the government programs, all insurance covers you will get. So that can be a stepping stone to the entry-level NABH program also. And that will, so the one more point I wanted to just tell you people about the National Family Survey is that the cesarean rate has gone up from we are at present in 2015, the rate was 35.8. Now it has got to, sorry, it was 17.2. It has gone to 21.5 now in the 2019 survey from 2015. So 2015 cesarean rate was 17.2. Now it has gone to 21.5. And in Kerala, it is from 35, it has gone to 38.9. But the neonatal mortality rate in Kerala is 3, while all over India it is 30, 10 times higher. So I personally feel, I'm not an obstetrician, but I personally feel it's a section rate of between 30 and 40. And one more point I would like to tell you that if you look at the private and public, the section rate in Kerala in private practice, both is the same. So the private and public people have giving the same care. So if you take Kerala as an ideal reference point, at a 40% section rate, between 30 and 40, you get a 3% neonatal mortality. While at a 21% section rate, you are getting a 30%, 10 times higher mortality all over India. So somewhere between the 20 and 40 is the range. I feel at around 30, I think 40 is ideal, but let's say, okay, we say, no, we need a lesser number of cesarean section. But if we go beyond 30, below 30, it can cause major problem for neonatal outcome and maternal outcome. So my request to all of you is that you're all obstetricians. So we have to, we must start a, Parag is also there. We must also start a multi-centric trial. It has to be 100 private and 100 public. You all volunteer to come forward. I'll give you the platform. Need to collect the data, and maternal morbidity data is also to be collected. Right. Not only mortality. Mortality is what, but morbidity. If there's a fistula, that's also bad, no? Of course. Why would we talk about extreme event? So this collection of data is very important for us so that we can tell the government. So all these things are interrelated. So, and the second last point, Madam Dr. Ranjana, I would like to make is that the Rishma was telling me that the WHO changed some guidelines and their partogram guidelines are changed and all that. So are those guidelines? See, we cannot go by WHO.
Yeah.
What has COVID taught us? That WHO says something else and we say something else. We must have our own guideline, and we must have our own Indian guideline. So we all have to get together. Forget academics. We need to create this guideline. Our ICOG, our FOGSI, everyone should get together and you create a guideline and have a declaration uniform that all our resident doctors will follow this guideline. All the professors should take a pledge. All the private practitioners should take a pledge, so that you have a uniformity of how to do obstetrics. I can't understand all of you. I can't, why there is so much different opinions. Why can't there be a single algorithm? Create that single algorithm. You are all such good people.
ICOG, we are working on the GCPRs again, na?
Madam, just create a single algorithm. कि patient pregnant हुआ ना, delivery होते एक ही algorithm follow करो आप. सबको वही क्या 3 दिन आप गोवा जाओ सब लोग और बैठ के एक algorithm लेके बच्चों को बताओ ना क्या करने का होगा. क्या इतना simple story को आप. Second last point is that artificial intelligence. Why can't you create a program? All Indians are so intelligent. Create a program where you put the parameters and the computer tells you कि अच्छा ये patient में induction करो, ये patient में cesarean करो.
Exactly.
बनाओ ना कि तुम्हारा primary ये ऐसा वो feed करने का, और computer tells you अच्छा section करो, ये करो. वो automatic Robin क्या बोलते हैं वो criteria है ना तुम्हारा Robson's criteria है, उसमें automatic classify करो. ऐसा इंडिया में इतने कंप्यूटर वाले हैं, उनके साथ बैठ के एक AI प्रोग्राम बनाओ ना. क्या है?
You know, I was reading that in Chandigarh the cesarean rate is 95%.
Right. So I'm just saying that. So I personally feel a 35 to 40%. Kerala is our ideal state. We need to take inspiration from Kerala and apply this to all our people. That's what I feel.
It's not only cesarean, it's about neonatal morbidity also. but which is very important.
Yeah, so the neonatal is 3% in Kerala.
Yeah.
And 30 times more, 29% to be precise in all India. Just look at the difference.
True, true.
Hrishikesh,
Okay.
I want to say one
I
thing.
think I said enough of obstetrics for the,
I want
next 2 months.
some help from you. Hrishikesh, I want some help from you. Why not that model which is the Keralites are following to be made available to everyone?
Yeah,
So
so
that
madam, what we need to do now is we need to have a national, instead of having, we need to have a conclave and come out with a, and maybe every state, we can give, see, we have got 30 states. Every state can be given a responsibility to create the one part of the whole. And then we join the part together. That is what we should do.
Yeah.
And standardize the care. And what is happening is that, to give you an example, my son is in the final year of DIVATRONE. वो उसको 2 ही चीज आते हैं, वो नॉर्मल डिलीवरी करता है या सिजेरियन करता है. The vaginal delivery, then I reasoned it. I said, listen, it's better. Why apply some vacuum and create neonatal morbidity? Forget mortality, morbidity. वो forceps लगाया, कुछ injury हुआ. तो I would not like. अभी वो कोई आया था तुम्हारा जर्मनी से, वो ब्रीच डिलीवरी. अरे मेरे बच्चे को वो अटक गया तो क्या होएगा? बच्चा अटक गया तो क्या होएगा? आप बोलेंगे हाँ 100 में एक अटकेगा. Why should that be my child?
Exactly.
Why?
True.
I'm not willing to take that responsibility. You
True.
just because you want to do a breech delivery, vaginal, it's all nonsense.
Really, sometimes
if that child has a palsy, it is a lifelong setback for that couple.
Exactly.
We can't have that.
Lifelong.
Very bad.
It's much better than in those cases to do a cesarean.
Yeah, we are not here to see. We should not focus on ourselves. Are ha, my great obstetrician. No, we have to focus on safety of the child and the mother.
Of course.
And one child also is not acceptable. One child which is injured is not acceptable in today's day and age.
Absolutely true. Yeah.
Anyway, I'm a IVF guy, so
no. These were real pearls of wisdom, Dr. Pai. They were real pearls of wisdom.
Thank you, madam. Thanks a lot. Sorry for this creating
No.
storm.
No, I think now, Dr. Parul, you take over the second session.
A very good evening to all of you. At the outset, I would like to thank Dr. Ranjana Khanna ma'am for making me part of this very successful webinar series named Scientific Sangam, and today being its 16th session. I now begin with our second topic of today, that is types of perineal tear and its management. And speaker is Dr. Parag Viniwale, sir. I now invite the chairpersons for the session. Our first chairperson is Dr. Ranjana Khanna ma'am. She is founder, president, Prayagraj chapter of ISOPARB. Ma'am has been National Vice President FOGSI 2017. She's ICOG Governing Council member 2021 to 2023. President of Allahabad Obs and Gynae Society 2013 to 2016. She's also organizing chairperson of National FOGSI Conference Obstetrical Dilemmas to be held at Allahabad on 6th and 7th of August 2022.
मैं फॉर्म नीचे दे दिया उपेंद्र भैया को.
अच्छा, मैं थोड़ा वेबिनार में हूँ ना, तो मैं जब खाली होंगे तो ले.
Please mute Dr. Babita. Please mute yourself. Dr. Babita, please mute yourself. Dr. Amit, please mute the others. Yeah.
Ma'am is also recipient of various awards like FOGSI Smriti Mylan Award, FOGSI Dr. D.K. Tank Reproductive Health Promotion Trophy, AIC 2015. Welcome, ma'am. Our second chairperson is Dr. Aruna Chaparia. She is Secretary Gorakhpur Obs and Gynae Society.
Dr. Parul, it's okay. It's okay.
Ma'am, it's very, I'll just finish it off. She's Director of Chaparia Hospital, Vice President, IMA Gorakhpur, and member of Menopause and ISOPARB Society. Welcome, ma'am. I now request Dr. Aruna, ma'am, to introduce our speaker, Dr. Parag Viniwale, sir.
Thank you, Dr. Parul, and good evening, everyone. Thank you, ISOPARB Prayagraj Society, for inviting me on this prestigious platform. It is always a pleasure to introduce a person whom you always love to listen. And it's my privilege today to read about Dr. Parag, who is an excellent orator, given many lectures in over 150 societies of FOGSI. Sir is Senior Consultant OBGY Pune, PG Teacher and Unit Head Kamala Nehru Hospital, Vice Chairperson ICOG 2021-22, President Menopause Society and OBGY Society Pune, Secretary ICOG 2018-20, National Website Editor FOGSI 2011-17, Peer Reviewer, Journal of OBGY of India, Chairman, Young Talent Promotion Committee FOGSI 2008-10, co-editor of book, Gynecological Manual on Adolescent Girl and Young Women, Yearbook of OBGY 2019, Exploring New Horizons of OBGY. Contributed many articles to books and journals. Sir is recipient of Dr. C.S. Dawn Prize, 51 All India Congress of OBGY, New Delhi, February 2008. Welcome, sir. Over to you.
Thank you very much for those kind words. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to be back in Prayagraj, though virtually this time, hopefully physically soon. And thank you, Dr. Ranjana, Dr. Amita, Dr. Chitra, and the entire team for having me here. And I'm really honored because I'll be speaking in front of Madam Manju Verma, who's such a great teacher and a very, very popular person, I must say. Thank you, Madam, for being here. And I also want to thank the Gorakhpur and Baroda OBGY societies, who are the academic partners. In next 15 minutes, I'm going to talk about one problem which really bothers us obstetricians, and that is perineal tears. If you look at my background, that's the logo for this particular year of Pune OBGY Society. And here we are talking about her and how important her life is. So my motto this year for POGS is Her Life Counts. And one of the problems which bothers us obstetricians is the perineal tear. We know that perineal tears are lacerations of perineum, which are a result of overstretching or too rapid stretching of tissues. And these are more commonly seen in primaries. All of us have seen these pictures of various muscles. We are aware about the anatomy of the perineum, but it is always important that we revise it quickly, because whenever we are dealing with a woman, even if you are giving an episiotomy, you should know what structures you're cutting. Similarly, whenever you are dealing with a woman who has a perineal tear, you must know what is going on. So these are the important muscles which control the pelvis, and they are important as far as the continence of stools is concerned. And the anatomy of anus sphincter and the rectum also has to be revised very well, because here we are dealing with a very, very delicate organ. And if the correction of the injury is not done properly, then it is a lifelong problem for that woman. So it is presumed that 1% of all vaginal deliveries are complicated by obstetric anal sphincter injuries. But with increased awareness and training, there appears to be an increase in detection of anal sphincter injuries. So probably few years back, we were not really worried about it or bothered about it, but now we are more and more careful about it. There was a time when we used to give episiotomy for all. Now we are using it restrictively. Similarly, we are now more aware about the anus sphincter, which is such an important organ for that particular woman. So obstetricians who are appropriately trained are more likely to provide a consistent, high standard care for anal sphincter injury, and they contribute in reducing extent of morbidity and even litigations which are associated with anal sphincter injuries. So whenever we are talking about training, I must make a mention of training program which is conducted by the Fernandez Hospital of Hyderabad, which really is so easy as well as so important for all of us to learn. A lot has already been talked about the risk factors, but whenever we are dealing with women, we always have to keep in mind that possibly this particular woman will land up with a perineal trauma. So women who are poor as far as nutrition is concerned, increasing age, we've already talked about young nullipara, but women who become pregnant, and that's thanks to the in vitro fertility technique, who are in their late 30s or even early 40s are more prone for development of perineal trauma. And we really have to be very, very careful when we are applying instruments. Mind well, instrumental delivery is really a boon when it is done properly, but if we miss it, then it's a big blunder for all of us. So all these factors we have to keep in mind that forceps delivery probably is the one which is more associated with anal sphincter injuries, and the incidence rises almost to the tune of 7%. So coming to the classification of anal sphincter injuries. So we always classify into 4 degrees. The first degree is whenever there is injury to the perineal skin only. The second degree involves injury to the perineum, involving perineal muscles, but not involving the anal sphincter. The third degree, which is again something which is quite common when we talk about overall incidence of anal sphincter injuries, and that is injury to the perineum involving anal sphincter complex. So 3A is less than 50% of EAS thickness. 3B is more than 50% of external anal sphincter thickness torn, and 3C when both external and internal anal sphincters are torn. Fourth degree is something which we really don't want to happen at any time, because it involves injury to the perineum, where the entire anal sphincter complex, that is external anal sphincter and the internal anal sphincter along with anal epithelium are involved. And fourth degree, there could be breach of the rectal mucosa as well. So here we should be very, very careful, not only in delivering patients, but also examining them properly after the delivery has taken place, because we should not miss out on any of these so-called smaller injuries, because these smaller injuries today can become fistulas tomorrow and make life hell for that particular woman. So we've already heard Dr. Amita speaking about prediction and prevention. I would just make these 2 statements. Clinicians need to be aware of the risk factors before they undertake any delivery, and we have to look for the injury at the earliest. So careful examination of the perineum is a must. And whenever we are giving episiotomy, mediolateral technique is something which is recommended, with careful attention to the angle cut away from midline, and it will definitely prevent extensions of episiotomy as well as injury to the anal sphincter to come. Coming to the management. So there are some surgical principles that we have to remember. So perineal trauma should be repaired using aseptic techniques. This holds true for all surgical procedures, but here equipment should also be checked, because this is something which may not be a day-to-day occurrence, but here the equipment has to be checked properly and the swabs and needle counted before and after the procedure. Good lighting is essential. So you need to shift the patient to the operation theater, give a proper position, make sure that there's good pain relief, and examine the patient first under good lighting, so that you don't miss out on any injuries. Difficult trauma should be repaired by an experienced practitioner in operation theater under regional or general anesthesia. So don't use any shortcuts of not using anesthesia. And when you have somebody who's senior around, do call him or her, ask them to review the diagnosis so that the best treatment is offered to a woman where there is a possibility of perineal injury. An indwelling catheter should be inserted at least for 24 hours, because we don't want the urinary retention to take place. A good anatomical alignment of the wound should be aimed at, and consideration has to be given to the cosmetic results. A rectal examination should be carried out after completing the repair to ensure that the suture material has not been accidentally inserted through the rectal mucosa. In fact, whenever you are suturing a regular episiotomy, do make it a point to do upper rectal examination after the episiotomy repair is done, and make sure that the thread has not entered the or it has not crossed the rectal mucosa. So following completion of the repair, an accurate detailed account should be documented. Please remember, we are living in an era of medical legality. So each and every small little thing has to be documented. Whenever required, take second opinions, make sure that you write in detail about the extent of trauma, how you have repaired it, what materials you have used. And it is important that we give correct information to the woman regarding extent of trauma. We should also talk about diet, hygiene, pain relief, and very important pelvic floor exercises, which she has to do as a part of post-operative care. So whenever we are assessing the patient, it is important we explain the patient. We must confirm that the woman that there has to be a confirmation by the woman that the tested effective local regional anesthesia in place. So make sure that the patient is comfortable. If in places where epidural analgesia is used, we always use a top-up whenever there is such a repair needed, or we can always use, if needed, a general anesthetic so that the patient is more comfortable. Visual assessment of the extent of perineal trauma must be done to include the structures involved, look for the apex of injury, and assessment of bleeding, because here again, we tend to underestimate the blood loss. So we have to be particular about the blood loss too. Rectal examination is done to assess whether there has been any damage to the external or internal anal sphincter, because again, this will tell you what procedure has to be carried out. And we should also look for damage of perineal muscles, if any. The timing of this systematic assessment should not interfere with the mother-infant bonding unless the woman has bleeding and that requires urgent attention. So even if there is trauma, if there is not much bleeding, possibly you could wait for a little while, allow the baby to be breastfed, and then explain the patient what has gone wrong, and then act as per the diagnosis. The woman should usually be in lithotomy position to allow adequate visual assessment of the degree of the trauma and the repair. And the position should only be maintained for as long as is necessary for the systematic assessment and repair. So who should repair obstetric anal sphincter injury? Already we have talked about it. This has to be performed by a person who is adequately trained in doing it. So a formal training is really important to have a correct suturing of this particular injury. The question is, do first and second degree tears require repair? And there has been a lot of debate on it, whether to suture the skin or allow it to heal on its own naturally. For first degree tears, there is generally no difference in post-delivery pain. There is less dyspareunia, in fact, in the non-sutured group at 3 months. Second degree tears usually require suturing, while the unsutured tears may result in a wide perineal scar. How do we repair it? For repair of external anal sphincter, either an overlapping or end-to-end, that is approximation method, can be used with equivalent outcome, where the internal anal sphincter can be identified. It is advisable to repair separately with interrupted sutures. And repairs of third and fourth degree tears should be conducted in an operation theater under regional or general anesthesia, and that has to be very, very clear. Coming to the anesthesia consideration, the level of anesthesia should be adequate for surgical repair so that the patient is comfortable and she cooperates with the procedure. If the patient has had an epidural, we can always give a top-up. For repair of third and fourth degree tears, redosing of the epidural may be required prior to beginning of surgical repair, as additional muscle relaxation is often necessary to relax the contracted sphincter, and a bilateral pudendal block with or without a local field block or a saddle block and general anesthesia are alternatives if there is no pre-existing analgesia. Coming to the suture material that I use when we are repairing the external anal sphincter, it can be done with the help of monofilament sutures such as polydioxine, that is PDS, or modern threaded sutures such as polyglactin, that is Vicryl. Whenever we are repairing the internal anal sphincter, then the suture size has to be a smaller one or a thinner one, where a 3-0 PDS or a 2-0 polyglactin may be used, and it will be beneficial because it will cause less irritation and discomfort to the patient. When obstetric anal sphincter repairs are being performed, burring of surgical knots beneath the superficial perineal muscles is what is recommended to prevent knot migration to the skin. But here we must also tell the patient that sometimes whenever you're using a non-absorbable suture or a long-acting absorbable suture, the knots may migrate to the skin and may cause local irritation. Coming to the suture technique and whether we should do a continuous subcuticular technique or an interrupted one. Now, so continuous subcuticular technique will have less pain in the perineum. There's no need to remove sutures, and there are reduced chances of dyspareunia. And Vicryl Rapid is found to be superior to catgut and polyglactin and polyglycolic acid. This is how the repair of fourth degree obstetric lacerations are done. The torn anal mucosa is repaired using a running stitch, but interrupted stitches are also acceptable. The internal and anal sphincter should be properly identified and repaired as a separate layer, and the external sphincter is then identified and repaired. The repair consists of either end-to-end or overlapping plication of the disrupted external anal sphincter and capsule using interrupted or figure of 8 stitches. Post-operative care is equally important. We must administer intravenous antimicrobials, cefuroxime 1.5 grams given at the time of surgery, and should be continued intravenously for 1 or 2 days, and then we can switch over to orally. Metronidazole also is important, and it should be administered every 8 hours at least for first 2 days. Foley's catheterization for 24 hours. Analgesic as and when required. So if you put in an epidural analgesia, you can continue giving top-ups through the catheter so that the patient has less pain. Lactulose 15 ml twice a day or isopgol 1 sachet twice a day is recommended for 2 weeks as a post-operative measure so that the patient doesn't have to strain for the stools. We should also talk about prognosis, because women who should be told that if the repair is good, they almost 60 to 80% of them would be asymptomatic at 12 months. But we must also remember that most women who remain symptomatic describe incontinence of flatus or fecal urgency. So this is something which has to be counseled to a woman who unfortunately lands up in perineal trauma. Coming to the secondary repair of episiotomy breakdowns. So it's not exactly the perineal tear, but here you have given episiotomy, there is infection, and then it leads to dehiscence. So traditionally, secondary repair of these breakdowns initially was thought to be deferred for about 2 to 3 months, but now it is concluded that earlier you do it, it is better, because the delayed repair would have an impact on the patient's social, physical, and even sexual disability because of continuous incontinence. There are certain advantages of doing an early repair. Of course, the disadvantage would be prolonged hospitalization. It removes the possibility of spontaneous closure, and sometimes early attempts at repair may fail resulting in need of subsequent surgical procedures. Wound care is important, and here sitz baths can be offered several times daily for the patients. For patient comfort, we usually recommend it 2 or 3 times a day. Women with clinically evident cellulitis should be treated with broad spectrum antibiotics, and whenever we are dealing with women with these injuries, these are the antibiotics which we have to keep in mind. What is the impact on subsequent pregnancies? All women who sustain an obstetric anal sphincter injuries in previous pregnancy should be counseled about a risk of developing anal incontinence or worsening symptoms with subsequent vaginal delivery. So it is worthwhile counseling them and giving them an option of elective cesarean birth if they feel so. How to counsel women? So here we must talk about their current symptoms, the degree of previous trauma, how bad was it. We also should talk about a possible risk of recurrence, the success of repair undertaken, and we must also assess the psychological effect of the previous trauma and then think of the management of labor. So this is the policy which should be implemented for women who have anal sphincter injuries, and there has to be written information given to the patient wherever possible so that she understands what care she's been offered to. It is also important for us to audit the injuries, the number of tears. We must also review about the systematic examination of vagina, perineum, rectum, etc. We also should look into a long-term continence rate following primary repair. So these are important take-home messages. So occult injury to the anal sphincter occurs frequently at the time of vaginal delivery and should not be missed. It is important that we do a thorough examination of the perineum in order to decide the mode of treatment that we are going to offer. Antibiotics may not be routinely administered prior to the repair of first and second degree, but for third and fourth degree, it is important that we give a good cover of antibiotics. Absorbable synthetic sutures such as Vicryl or Vicryl Rapid are preferred to catgut because these are the ones which significantly reduce short-term perineal pain and requirement of analgesics. For the aim of reconstructive surgery is to restore not only the continuity of both the sphincters, but to also to create a thick perineal body and a rectovaginal septum. So reapproximation of the internal sphincters is really important, and in general, early repair of an episiotomy breakdown is desirable to minimize both short-term and long-term perineal pain. So thank you very much. And once again, thank you, Dr. Ranjana and Team Prayagraj for having me with you all. Thank you.
Dr. Parag, that was a wonderful talk. And as emphasized by Dr. Amita and you, that the extremes of ages, it's very important to be cautious about these perineal tears, and especially large fetus when you're expecting trouble. Instrumental delivery, the incidence has reduced dramatically now with the coming of the consumer forum. I remember as house surgeons, we were so enthusiastic to conduct deliveries. And then we were taught these 3 basic things, that if by chance you give a median episiotomy, the bleeding is going to be less, but there's a lot of risk of trauma to the anal sphincter. And be very careful. Now, if by chance, if you give a very lateral episiotomy, it's going to bleed heavily and chances of hematoma formation. So the best way out is a mediolateral. And we were also told that if by chance you have given a median episiotomy, then if you are expecting that the baby is bigger than what you were expecting, go in for a J-shaped incision, because that will save the trauma to the anal sphincter.
Absolutely.
These were the things we were so particular about. And another thing, your pointer on putting a hand in the rectal area, a finger, while you are stitching the episiotomy is very, very important, because over enthusiasm in taking deep bites often ends up in including the rectal mucosa, and then it can break down later on to form an RVF. So that becomes very deadly. Another thing I wanted to talk about was the sometimes very small but very vicious periurethral tears. They could be so tiny, but they bleed like horribly. They bleed, and they put you at your edge, and then you find that little tiny tear which is, you know, doing it all. And another thing which really upsets one is after you've stitched the episiotomy, and after half an hour or 1 hour, the patient's husband comes and says, "Usko to bahut dard ho rahi hai," and then you open and you see a huge big hematoma over there. So that is really very unnerving when you have to open it. By chance you have, in a hurry, you've not done the proper hemostasis, then you have to pay the double price for that by opening it up again and then explaining, you know, the worst thing is counseling then, that this could have happened and it has happened. And sometimes hematomas are so vicious that you may need even blood transfusions.
Right.
So all in all, perineal tears, they are seemingly a small topic, but actually they are very, very important in a woman's life, because I remember one of my relatives, she got delivered in Delhi and she had perineal trauma. She was given an episiotomy as a primary, but she had so much trouble in passing feces, flatus. So I think there was a small trauma there, but she was so shy to show me. And I don't know, I counseled her that go in for an elective Caesar, but again, she went in for a normal delivery. So, I mean, that was rather daring of that obstetrician, but well.
Can I say something?
Hanji, of course.
I mean, we have been teaching all the students to stitch the episiotomy in 3 layers, starting from mucosa,
yes,
and then to muscle, and then to skin. But now I realize it is better to stitch the muscle first.
Yes.
Because the exposure to the apex of the muscle is better when you don't stitch the mucosa.
Exactly.
So stitch the muscle first, number one, and then you stitch whatever you feel like stitching.
Exactly.
So the chances of hematoma is much less, are usually not there, and the stitching also is very proper.
Because
so that should be the way of stitching the episiotomy. Number one, and number two is that in my experience from 1972, I have never seen a median episiotomy. I've seen a tear, but I've never seen a person giving either a median or even a J shape. We have always gone in for the mediolateral. So we speak about it as a teacher or whatever you say,
yes,
but then mediolateral is the episiotomy that should be given.
That is mostly a tear, but if it's there, then immediately go in for a J, because that way at least the anal sphincter is safe, because the deadliest is injuring the anus actually. And of course, you're right, because especially if the mucosa has extended very high up, so you end up repairing that, but then you miss out on some of the muscles. And then that continues to bleed later on. So that was a wonderful talk, Dr. Parag. And
yes, very nicely explained.
Very nice. And you stressed upon the thing that was most important, that is the stage 4 and the stage 3, which is the actually important and the most dreaded. So, and of course, we are looking forward to your coming on 6th and 7th. I repeat.
Thank you. Yeah, thank you so much. I'll just add one thing. Madam Manju Verma, what you have suggested is absolutely correct. I mean, we have also started doing that in practice, especially when the episiotomy is very deep. Then we always tend to take the muscles first, because taking mucosa is easy when there is adequate analgesia. But if the patient is not very comfortable, it is difficult for us to, reach out to the deeper muscles and then take stitches. So this is something which we've been following for last few years. So thank you very much, ma'am.
Because with experience and with gradual deliveries, you find that it's better if you repair that first, rather than the standard teaching of doing the mucosa first.
True. The hematoma chances are less.
Yeah.
Sure. Can I ask something?
Yeah, you can.
Chitra,
Can't hear you. You're muted.
No, no,
Now
no.
you said.
Yeah.
So
Go
you
ahead.
and Dr. Amita both have emphasized the importance of using the type of suture material and its documentation. So any specific reason for that documentation of suture material which is used?
See, basically, in the era of medical legality, there has to be a transparency. You have to be honest with the patient. See, a perineal injury is something which can happen during the course of labor, and then if it happens on its own, you just have to counsel the patient that this is a known complication, and especially when you are suturing it, it is why we mention it, because it also indicates the standard of care that you are providing. So whatever the literature is saying, that is what we are using. So we are providing the best possible care. And if God forbid, if something goes wrong in spite of your efforts, then at least you are medically legally safe, that you have offered the patient whatever is recommended and whatever is best possible.
Thank you, sir. Thank you.
Let's go ahead with the third session. Parul.
Thank you, sir, for the wonderful talk. Now we move on to our third session, and the topic is rupture of unscarred uterus. Our speaker for the session is Dr. Manju Verma, ma'am. I would now like to invite our chairpersons. Our first chairperson is Dr. Sadhana Gupta, ma'am. Ma'am is co-chair SAFOG NCD committee, FOGSI representative to SAFOG 2018 to 2021, ICOG governing council member 2015 to 2021. She has been vice president of FOGSI 2016, corresponding editor of Journal of OBGYN India and Journal of SAFOG. Currently, she is director and senior consultant at Jeevan Jyoti Hospital and Medical Research Center. She is a recipient of numerous awards for her scientific research and FOGSI publications. She has also been organizing chairperson of various national and international conferences. I welcome you, ma'am.
It's okay, Parul. Thank you. Warm welcome to everybody.
Our second chairperson of the session is Dr. Garima Trivedi. CV, please. She is Director Ma Bhagwati Mother and Child Care Center, Prayagraj. I welcome you, ma'am. Now I request Dr. Garima to introduce our speaker, Dr. Manju Verma, ma'am, and Dr. Sadhana, ma'am, to give concluding remarks thereafter. Over to you.
Thank you, Dr. Parul and ISOPARB Society. It's my privilege to introduce Manju Verma, ma'am. Ma'am needs no introduction. She's our mentor and teacher and always have been very dynamic person and guide for all of us. Madam is a past president UP chapter Obs and Gynae, certificate of honor in medicine, Dr. Shiv Narayan gold medal, VC Pant gold medal, Lakshmi Ratan Pandey silver medal, Chancellor's bronze medal, President gold medal, Prashansa Patra and silver medal for her meritorious family welfare work. Shri Prabhu Dayal Baveja,
I think everybody knows me.
Served as lecturer, reader and professor in State Medical College UP, chapter in 3 books, 100+ scientific papers in national and international journals, oration, guest lectures in national and international state and level conferences. She is a technical expert, Public Service Commission, UP and MP, examiner in state and other university, and president in AOGS. Welcome, ma'am.
Thank you, Garima, for your kind, introductory words.
Welcome, ma'am.
Very, very good evening to everyone. And I am thankful to Ranjana and congratulations to you and your whole ISOPARB team for the successful conduction of this scientific Sangam. And this is the Sweet 16 Sangam in which I've been included as one of the speakers. So Sadhana, welcome. Garima, welcome again. So I would like to share the literature which is available on rupture of unscarred uterus. I would like to say rupture, the word as such is so horrifying. When the rupture occurs of the uterus, you can imagine the amount of catastrophe it is going to cause and in the mind of obstetrician and everybody around. So the most important thing is that it is also associated with the high incidence of feto-maternal morbidity as well as mortality. The fortunate thing is that it is not very common, that is an unusual, and unfortunately the onset is so sudden that one may not be able to find it. And another thing which I would like to say here is that it can occur during pregnancy at any time, can occur in the 3rd trimester, but the most common time at which it occurs is during the labor. So I say that there are certain things that one must know is that the primi-gravidas and women with unscarred uterus are supposed to be immune to rupture. This is the concept which is being given to all of us, but then one must be very, very careful when dealing, because most of the accidents occur when the person is unaware. So that this is one thing which one should take care. And another thing that one should keep in mind is that the time factor is the most important. Every second before the intervention is very, very crucial for the survival and the of the mother as well as the fetus. Now, coming on to the definition, everybody knows that it is a non-surgical disruption or tear of the myometrium of the with or without serosa, the outer covering, and with or without expulsion of the fetus and placenta into the abdominal cavity or peritoneal cavity. Now, one should keep in mind that unscarred uterus, it does not have any identifiable etiological as well as the risk factors, but yet to enumerate. Before that, I would like to say, already said that it can be complete or incomplete. So complete, I've already said, when the myometrium is totally involved and it communicates with the peritoneal cavity, and incomplete when the serosa is intact. Now, coming on to the sites where the uterus can rupture is they can be fundal, can be lower segment, can be lateral, and the most common one are basically the corneal ruptures, and they are usually right or left. Any of the cornea can rupture, but the left is more common. As we know, the left positions are also very common. Coming on to the incidences, I think it may vary from 0.3 to as little as 0.007 in Netherlands. But we are in India, and I would like to comment the incidence from the JIPMER study was conducted on 32,000 deliveries, and they found an overall incidence of uterine rupture as 0.28. Now, I won't go into the details of this. And then unscarred uterus, again, you can see, I will continue with the JIPMER study, that there were 93 tears amounting to 0.2. But when we come on to the unscarred uterus, there were only 33%. That means approximately 32 patients with unscarred uterus has rupture of uterus. And after all of these 33%, most of them, that is 14% out of the total, presented having a rupture outside and coming to JIPMER. So this is one thing that one should know about. Coming on to the neonatal, the risk factors, the most common one, just to enumerate as anatomy, is that the congenital uterine anomalies, which is common in 1 in 200, but the overall incidence in congenital anomaly has been rated to be 0.8, 2 out of 25 by Abhilasha, while other type of uteruses, minor uterine anomalies which can go in for rupture are arcuate uterus, septate uterus. The major uterine anomalies can be a unicornuate uterus, didelphus, or bicornuate uterus. Besides that, even the rudimentary horn, hypoplastic uterus, and congenital defects like the collagen diseases and then connective tissue disorders in the form of Ehlers-Danlos syndrome and Loeys-Dietz syndrome. Once the uterus in ruptures without any scar, they given in one should investigate for these two as one of the factors. Then most commonly they occur. This is trauma. The trauma is another factor, so that basically occurs. It is associated with pelvic fractures and bladder injuries, and they usually, if they occurring at the area of fundus. So uterine hyperstimulation, as we know, this is one of the most important cause as far as the risk factors is concerned, and oxytocin being used as for reduction or augmentation, and these are the number of studies which say that the incidence can vary from 4.34 to 12% if the oxytocin use is not done properly. The misoprostol or dinopros being used for cervical ripening in second trimester or even in the third trimester for induction of labor has also been associated to cause uterine rupture. The another thing is the obstructed labor due to cephalopelvic disproportion that can result in uterine rupture. The next, coming on to the traditional risk factors, the maternal age, it has been found out that if the overall incidence is 1.1, but if the age is more than 30, then the incidence is 1.4, and it falls down to 0.5 when the patient's age is less than 30. The grand multiparity, if it is more than 5, the incidence is 31. And if it is more than 4, it is 32. You can see that the parity makes a lot of difference as far as the rupture is concerned. Uterine distension due to polyhydramnios and multiple gestation, because there is a serial distension of the uterine muscle fibers, and this can result in in the rupture of the uterus. Multiple gestation, as we all know, results in uterine distension, and it has been found out as compared to the singleton pregnancies out of 24,000 some odd number, the incidence was only 0.9 as compared to twin pregnancy in which it is found to be 1.1. That means out of 535 twin pregnancies, only 6 resulted in rupture. The fetal conversion is basically the consideration. Fetal macrosomia, one can see easily that from 35,000 grams, the incidence range starts from 0.9 and becomes 2.6 when the fetal weight increases to 4,000. If the gestational is more than 40, it is more likely to go, the chances of rupture are there, because you are going to do interventions to deliver the baby. During labor, the chances of rupture are because of dystocias, internal podalic version, external podalic version, if it is done forcefully, and under general anesthesia, breech extraction, shoulder dystocia, if it has been taken out, chrysalis maneuver, and malpresentation. Besides that, these may be difficult manual removal of placenta, especially if it is an adherent or increta or percreta. So these may be during labor. And then coming on to one thing which I have not been able to mention is that in our times we were told that it is basically, in sometimes if it is a retroverted gravid uterus which gets incarcerated below the symphysis pubis, there is an anterior sacculation. And this sacculation, the muscle becomes thinner and thinner, and there are chances of rupture of uterus much more. Similarly, if there is an acute anteversion and anteflexion, there are chances of posterior sacculation. So one must think also these conditions as the predisposing factors. Now, once a patient comes, they presents, and the presenting symptoms or the clinical signs and symptoms depend basically on the time, site, and the extent of the uterine defect. Classically, they can be abdominal pain and vaginal hemorrhage. I won't go into the detail about the published hematuria. The most important is basically the cessation of the uterine contraction. The features of shock may be there. Then intra-abdominal hemorrhage can give rise to the chest or the shoulder tip pain, easily palpable. On examination, fetal parts will be easily palpable. There may be a suprapubic bulge, or if the lady is in labor, there may be a recession of the presenting part. So that also gives the indication that there are likely chances of uterine rupture. The most important thing and the consistent thing to think that the rupture has taken place is the abnormality in the fetal heart. Now, fetal bradycardia is supposed to be the first sign most of the time, and studies have reported that in 87% this may be the finding. Then prolonged deceleration can be there. There can be fetal distress. There can be fetal bradycardia or prolonged deceleration. Now, atypically, especially if there is an incomplete rupture, the chances are that the abdominal pain and there may be localized pain and tenderness. And but the bleeding, since it is much less, the signs of shock develop very late, and therefore it can be easily confused with accidental hemorrhage. Now, coming on to once we have come, the management, the golden rule is that we know that the uterine rupture is a clinical diagnosis, and there must be a high index of suspicion by the care provider. It should be first ruled out in all pregnant women when they are presenting with acute abdominal pain at any time of the gestational age. Now, coming on to the investigation, the most important, I already said, there are chances the fetal heart is the best prognostic factor or pathognomic factor resulting in fetal distress. So CTG is a must, and that we can diagnose it very easily by finding out the baseline variability and various fetal heart rate abnormalities that can be there. Besides that, there can be imaging techniques in the form of ultrasound or MRI, and there can be even a mechanical device like intrauterine pressure catheters which can be used. So coming on to the ultrasonography. Now, there are two things. One, we can have a threatened rupture, we can predict a rupture, or if the rupture has occurred. So all the three things can be diagnosed by ultrasonography, and it is the safest and the most useful technique. Before rupture, if the membrane, the uterine wall is thinner than 2 mm, the chances, the positive predictive value for the rupture is 100%. While if the wall of the uterus is less than 3.5 mm, then you cannot predict. The positive predictive value is only 11.5. On the contrary, if the uterine wall thickness is 4.5, it has got a negative predictive value. That means the uterine scar chances are not there, and therefore it is 100%. Then once rupture has occurred, then these ultrasonographic findings are that there can be an identifiable myometrial defect anterior in the form of an hypo or an echoic line. There may be a protrusion of amniotic sac. There can be a large empty uterus with gas bubbles, and the fetus may lie into the peritoneal cavity. There can be extrauterine hematomas like in the broad ligament if there's a lateral tear, and there can be hemoperitoneum or free fluid being exhibited on ultrasound. Then MRI, I won't go into the details, it is just gives you the confirmation, but we don't have much time to do MRI in patient because we have to institute the treatment first. And therefore, even intrauterine catheters, if they are being put in, they are not of much value, except academic value that there may be loss of uterine tone, but not very conclusive. Though coming on to the actual surgical management, if there's a threatening rupture, we all know do a cesarean immediately, if one should do. Then coming on to, if a rupture has occurred already, then there are certain things which one has to take care of. That since the patient is in shock, one has to go in for intensive resuscitation. There has to be done a laparotomy, emergency laparotomy, with, of course, the operative and post-operative care that has to be taken care of. Then this is again details that if the shock is there because of hemorrhage and dehydration, one has to go in for the intravenous blood transfusion or blood component transfusion. But the moment you think that you can do a laparotomy, straight away go in for laparotomy if you want to save the mother. So there are certain broad principles as far as the operative management is concerned. Uterine repair if possible, right? That should be done. Hysterectomy is indicated if hemorrhage persists, and the hysterectomy can either be total or subtotal, depending upon the site of rupture and the acumen of the surgeon who is doing it. There is what type of thread or needle or the suture, whether interrupted or continuous, it is immaterial. Whatever the person thinks, there is no evidence that they are going to change the future chances of rupture. In cases of lateral rupture, especially, one has to be very, very careful because there are chances that you may not be able to control the bleeding. And therefore, one has to do ipsilateral hypogastric artery closure, so that you can stop the bleeding and then you can do the proceed further. If the once the repair has been done, there are chances of recurrent rupture in the subsequent pregnancy, and the incidence has to be reported as 20%. Now, depending upon to continue, one should remember that studies have shown that if the baby is taken out within 10 to 37 minutes of the uterine rupture, the chances of fetal morbidity and mortality is much, much less. So try to be as quick as possible. And as far as the surgical treatment is concerned, one has to do, depends upon the type of type, extent, and degree of uterine rupture, the amount of hemorrhage that is occurring, the parity of the patient. This will modify the type of operation that one has to do, the edges of the rupture, whether they are ragged or irregular. Then there are general condition of the mother that also, one of the factors to institute what the type that can be done. Then mother's desire to have further childbearing. Now, we all know there are only 3 options with her: either do a hysterectomy, take the uterus away, and save the mother. And this can again be total or subtotal. There can be only repair that can be done. But there are typical, definite indication, which I'll tell in the next slide. And if one is not able to, not being able to be used to do a hysterectomy, then one can do a repair as well as sterilization, so that consequences of further rupture are not there. The repair should only be done when there is a desire for the childbearing. If there is a lower uterine rupture, lower segment uterine rupture, and it is a transverse rupture. Longitudinal ruptures, one has to be very, very careful because there are chances of more rupture in the longitudinal tears. And if the extension of the tear is broad ligament to the broad ligament, cervix or paracarpus, then one cannot do it easily. Hemorrhage has been controlled, then you can go in for repair. And if the condition of the patient is good, and the coagulopathy has not developed, because usually they come quite late to the hospital. Hysterectomy should be considered as the treatment of choice whenever there is intractable bleeding that is occurring. And if there are multiple tears, or there may be low-lying tears, and all these cases, hysterectomy should be the choice of operation that should be done. There are complications that can occur, post-operative infection, as they are mostly coming on from outside, getting all interventions done. Damage to the ureter can be there, especially in the lateral tears. Amniotic fluid embolism is one of the things which one should be careful about. Massive maternal hemorrhage can occur. There are chances of disseminated intravascular coagulation, pituitary failure because of the excessive hemorrhage that has occurred, and there may be chances of bladder rupture or bladder injury. Now, coming on to the consequences and the meta-analysis, 8 meta-analysis, the neonatal, they have found hypoxia and anoxia in 8%, acidosis and umbilical artery pH less than 7 in 33, Apgar score less than 7 in 26, admission to NICU in 43, and perinatal death. I'm saying this is one thing very, very important. You may be able to save the baby immediately, but there are chances that you may lose the baby in 28 days. So one should be very, very careful whenever we are taking, doing laparotomy. Coming on to the maternal consequences, there may be severe loss. As we know, there can be chances, if bladder rupture is there, to do a cystostomy. The hysterectomy, of course, is the choice of operation, and the chances of maternal death in developing countries has to be, 8% as compared to 0.32 in the developed countries, simply because the patients are coming late to the facility. Coming on to the prognosis, as we know that the perinatal death as well as the maternal death is very, very common. Then the outcome, of course, I will say that one should say that the mortality appears to be higher in women who have unscarred uterus when the uterus is scarred. Because when the uterus is scarred, you are already mentally prepared that she's likely to develop a rupture. And with an unscarred uterus, your mind will not think on those lines, and therefore mortality is higher if the unscarred uterus ruptures as compared to the scarred uterus. And death is, of course, is not very common, but yes, overall mortality has been rated to be as 15.9, with perinatal morbidity ranging from 8 to 56%. In conclusion, the uterine rupture is a rare but catastrophic obstetric complication with an overall incidence take as to be 0.0% of all the pregnancies. The diagnosis is basically clinical and should be suspected. And most of the patients, they will require intensive resuscitation. The surgery has to be definitive. Indication for repair with or without tubal ligation should be done with definitive indication, which I've already projected, and proper counseling as far as the future pregnancy is concerned, because there are chances of rupture of repair in the next pregnancy. Now, Ranjana is already done, invited, but I would like to say that you are all invited to the physical conference that we are going to be held at Prayagraj on 6th and 7th, and everybody is, invited and welcome to attend this conference. This is a physical conference occurring on 6th and 7th of August. Then today is the World Telecommunication Day, and I think we are celebrating it by communicating with each other. So wish you a very good telecommunication day to all of you. And this is how we are able to communicate with each other and see each other's faces because of this technical advancement. And then I would like to say that safe motherhood should be the objective of every obstetrician. So जो mother is giving, a succession of हिंदी में बोल रही हूँ कि जो एक जन्म का धारा बनाई जाती है, माँ से बच्चा, बच्चे से फिर उसका बच्चा, that should continue. And for patient hearing, I say thank you very much.
So it was a real revision, and the challenge was the rupture of unscarred uterus, and with a few very important things like it is being a multi-para, and the previous one thing which are the new technology like hysteroscopic resection, metroplasty, which are being done by the endoscopic, they also prone, because there is apparently no scar, but they are very, very prone to rupture in antenatal period as well as in the labor.
Right.
Important thing, actually, I reviewed many cases when I was listening to Madam's talk, and few cases which we really trouble with life and death. What happens? A rupture occurs suddenly in second stage. And when we are expecting the baby to deliver, and suddenly the mother is like having the unstable vital, and sometimes two cases I remember, the baby delivers and just after the patient is collapsed. And both cases there was we could say that it was a postpartum or during second stage of labor. And at that moment, actually no ultrasound, nothing you don't have any time, but we have to be very, very quick in arranging all the blood transfusion and going for laparotomy. And the third important, like what I have now just remember two things. When we opened the patient for unstable vital, 2 times I got secondary abdominal pregnancy. So they were looking like rupture. One was IUMT and one was secondary abdominal full-term live baby. And I say, where is the baby? Where is the uterus? And that secondary abdominal pregnancy is one of the published in the Jogi also. So these are also issues which present like rupture uterus or the vague things, but it actually appeared as a secondary abdominal, which can sometimes be really, really life-threatening because of placental bleeding and many things. For ultrasound, I will say the imaging people are too much dominating on us on MRI, but actually any level of uterine thickness does not give you actually no idea. Both the VBAC, the researcher says, but the Western world has returned a U-turn on VBAC. They say the vaginal birth after cesarean section is not safe because only in second stage we do. And even in a normal uterus, thickness cannot, because what is happening in the labor. And the fourth thing, I think everybody will say, the oxytocin was a safe induction agent. Ranjana gives always talks on the induction, but the misoprostol and the Serviprant, we cannot revert. There is sudden hyperstimulation and we don't have any drug to revert it.
Exactly.
So should be very, very cautious. For a live baby, misoprostol can be a real, not a very good choice, and we have a hyperstimulation, fetal bradycardia, and sometimes all the things happen, go together, and we don't know whether it is rupture or severe degree of fetal distress or what. So always be very, very alert while conducting labor. Any woman from primary to multi can have this rupture, and patient is shouting and suddenly she is down and thinks that is uterine rupture because she is having low BP 30, 40. So thank you very much, Madam Manju. It was like chairing your session is something I like it. Your student and your disciples are chairing your session. So the reason when we used to do internal podalic version, MRP, yes, in residency, I did one internal podalic version and patient collapsed just after that. So obstetrician always on the toe, and it is what all the webinar to everything.
We were not supposed to say this, that we were performing internal podalic version. Otherwise, they would have failed us in MS.
Once upon a time, the patient is second twin, like second twin with the transverse lie and what we could do. So once upon a time we had, that was residency. But now the new technology has also given a lot of things. And that we know is scar, but then this hysteroscopic metroplasty and this thing and Asherman first of all, and then when the patient become pregnant, anytime rupture. So we have to be like take it also as a with a pinch of salt. Thank you, thank you, Ranjana, for the invite.
You're welcome. Now you are actually invited for the physical conference 6th and 7th August, and we want you both the days, Sadhna. Since your association with Allahabad Society is from 2016.
For everything and for anything in your. Thank you.
Sadhna, I think Sadhna, Gorakhpur people have got a lot of experience as far as the obstructed labor is concerned and VVF. We were told that in Gorakhpur a lot of obstructed labor.
Yes, when Dr. Urmila Gupta, when I came from Agra to this thing, actually fissulas and their thing, it is 86, but now
no, of course.
Now everywhere. It has changed everywhere. Modern obstetrics has come in.
And now the PSCs also have got a good labor room. Not that bad patient now. Not that.
Maternal mortality is stepping down now gradually.
True.
So I think, Dr. Parul, you hand over the session to Dr. Chitra. Yes. Dr. Chitra, take over, please.
Okay. Good evening, everyone. So after such wonderful talks, now we have come to our last session. And speaker of this session is Dr. Archana Dwivedi. She will be speaking on cervical tear types and management. I remember when we were in UG and PG, it was a rule we have to explore the cervix with 3 forceps after each and every vaginal delivery. So now we explore only when we have suspicion, high suspicion, or there is unusual bleeding. But that time we were supposed to explore each and every patient for cervical tear. Such was the fear of cervical tear. And
Chitra, I would like to tell everyone is the Vice President of ISOPARB Prayagraj and very, very dynamic worker. So
because of you, ma'am, you are so inspiring. Thank you so much, ma'am. So now it's my proud privilege to invite chairpersons for this session. And I invite Dr. Amita Jaipuriyar, President of Gorakhpur Obs and Gynae Society. Madam is Consultant Gynecologist and Obstetrician, Jaipuriyar Medical and Research Center and Girl Hospital, Gorakhpur. She is also Secretary of Gorakhpur Menopause Society and Secretary of ISOPARB Gorakhpur Chapter.
Thank you, Dr. Chitra. Thank you. It's okay.
She has been organizing Secretary of workshop on maternal mortality, Northern FOGSI 2010, Saving Mothers Conference 2019, SAFOG. And she has various papers, presentations, and publications. And Economic Times has given her Most Promising Gynecologist of the Year award in 2021. So we welcome you, Dr. Amita. Second chairperson of this session is Dr. Babita Shukla. At present, she is Scientific Secretary, ISOPARB Gorakhpur Chapter, Vice President, Gorakhpur Obs and Gynae Society, and Secretary, Women Doctor Association, Gorakhpur. And she has honors and gold medals in undergraduates, and she also has paper presentations. Her areas of special interest is high-risk obstetrics, fetal medicine, and obstetric ultrasound. I welcome you, Dr. Babita, and I request you to introduce our speaker to the audience.
Thank you so much, Dr. Chitra, for such good words. I'm very thankful to ISOPARB Allahabad for giving me this opportunity. Now it's my privilege to introduce Dr. Archana Dwivedi. At present, she is President BOGS 2021. She has held several important posts as President BMS, Vice President BOGS, and Secretary WTWIMA in 2021. She has her key interest is in pregnancy, laparoscopy, and vaginal surgeries. Winner of several awards, be it the Jagdishwari Mishra Award at ISOPARB and Gujarat Gynae Excellence Award.
Sorry to interrupt.
Award of.
Thank you so much. Let us proceed.
Midlife Clarity Award. So warm welcome, Dr. Archana. We all know you very well. We didn't introduce you so formally.
I think I would like to introduce myself as a humbled and honored student at this platform with Dr. Verma here and Dr. Ranjana Khanna madam and all dear friends whom I can see. And Amita Di, Priti madam is here. So I think I would just like to share the screen. Thank you, chairpersons, for very kind introduction for this evening. And I have been the proud student to hear my own professor over here and learning still the tips from her. So the topic which was given to me is cervical lacerations in labor and how to deal with it. So let me come to the risk factors first, because the previous speakers have made the job much easy for me by introducing the perineal tears and the authentic data and how to tackle the tips. So here we have to keep in mind the patient who has got a history of gestational diabetes or is into difficult labor, having shoulder dystocia, or we are going to deliver her with vacuum or forceps. There's a history of cerclage, there's cervical conization history, as well as DNCs, which is very important factor when we talk about cervical rupture. And added factor may be hypertonus, which can be caused by prostaglandins or oxytocin, as Dr. Sadhana Gupta madam pointed it very nicely. So why are we concerned about it? Because cervical lacerations has been a very known cause of postpartum hemorrhage. And whenever there's a stiffness and dryness of the tissue is the underlying cause which causes the occurrence of lacerations and fissures. Sometimes we encounter multiple lacerations also because there's a damage to the integrity of the cervical stroma, which contributes, which is also a contributory factor for cervical insufficiency and preterm birth. Unyielding cervix, and there are several mechanisms which are being postulated because of strong uterine contractions when we are going for augmentation of labor, especially with misoprostol. And prior to the dilatation of the full dilatation of the cervix, oxytocin administration, which can cause excessive pressure in between the presenting part and the resistant cervix. Hence, there's a rupture and the baby has to come out. This may impair the cervical blood circulation, which results in edema, necrosis, and revulsion of the cervix. So pathogenomically, knowing what is causing the cervical tear, we can briefly divide it into three parts: iatrogenic, rigid cervix from the previous cervical operations, or the precipitate labor, which can be the cause of cervical tear. Cervical tear or the vaginal tear should be suspected when PPH is there, and in spite of all well-contracted uterus, you see a gush of bleeding coming. It is the time to explore the cervix and vagina for the tear under the good light to diagnose it. The reported cervical injuries, or which we come across commonly or uncommonly, the most common stands is left lateral cervical tear, which is very, very common in all of our practice. Then there are bucket handle tear, which is a laceration of the anterior or the posterior lip of the cervix, so that it hangs like a handle of the bucket. And it is the rarest type of cervical laceration, which we all wish it should not occur to anybody. Tears can present as a complete detachment, also known as cervical avulsion, or they can be an annular detachment of the cervix. Most common being the lateral cervical tear. These are some wonderful diagrams I've copied from the net actually. This is the partial annual cervical tear. This is the posterior cervical tear. And this is the bucket handle tear, which was reported in the case of a cesarean section. This is a gangrenous posterior lip of cervix, as you can see, where the cervical tear is extending to the vaginal vault. And this is a very unfortunate type of a complete or the partial cervical avulsion, which went unrecognized. I would not call it as negligence, but as we all know that we are not very prompt in inspecting the cervix as we used to do in our residency days. This is where the occult cervical avulsion can come unnoticed. So whenever we are dealing such type of patients, the general clinical principle remains the same as all of our teachers have spoken previously. Rapid initial assessment is very important. Talk to the women and their families, give emotional or psychological support, which is very important for us in the medical legal era, where we have to tell the complications. And when we are dealing after, say, period after 4 weeks or something where the cervix is not healing as we are like wanting it to heal, this psychological support would help us in a long way. General care principles remain the same. If there's a requirement of blood or blood components, we should get it arranged. Antibiotic therapy, anesthesia, analgesia, operative care principles should be followed. And especially the newborn care principles and the provider and the community linkage is very, very important when we talk. So coming to the repair of the cervical tear, we should review the general care principles and apply the antiseptic solution to the vagina and the cervix with the emotional support, proper consent and encouragement to the patient. Anesthesia if required. We should be very judiciously using that, because many of the cervical tears can heal on its own and they don't need to be stitched actually. But the tears which are high and extensive, give pethidine or diazepam, IV slow ketamine can be used, and ask the assistant to massage the uterus and provide the fundal pressure properly. So how to explore? This is the aseptic precaution should be taken, a proper light should be there, patient should be placed in a lithotomy position, insert the speculum and retract the posterior vaginal wall to see the cervix through and through its length. Ask the assistant to push down the fundus of the uterus gently so that we can visualize it more clearly, because the gush of the blood is there. You have to clean and visualize the whole of the length of the cervix. Hold the anterior lip of the cervix with a sponge holder and trace the whole of the cervix with another sponge holder forceps in a clockwise manner. Identify the cervical tear and grasp its both the margins of the tear with the sponge holder again. So it is very important to inspect and then to start acting. Small cervical tears, minimally bleeding, should heal spontaneously with no suturing required, and they actually don't land up into any complications. But a tear with active bleeder or longer than 2 centimeters warrants repair, and large cervical tear, heavy bleeding, a 2-0 absorbable figure of 8 sutures in single layer is fair enough. Place the initial suture above the apex as I have shown in this figure to stop the bleeder, active bleeder. And to control the retracted arteries, which are very much likely to this hyperperfused cervix of the perineum. So by grasping and closing this tear, there are certain side tears. Gently pull in various directions to see the entire cervix. You can use the zero chromic catgut, though we are not using it anymore. We are going for the polyglycolic sutures only. And there is sometimes a condition where the apex is very difficult to reach and ligate. It may be possible to grasp it with the artery or the ring forceps, leave the forceps in place for 4 hours, explain to the patient that we are taking time to stabilize you and getting to the apex, and do not persist in attempts to ligate the bleeding points, because such attempt may increase the bleeding and it would not be a good thing for the patient and the obstetrician itself. After 4 hours, open the forceps partially but do not remove it, and another 4 hours, remove the forceps completely. Only few cases which may require laparotomy to repair the cervical tear if it is extending beyond the vaginal wall. So there are various methods, but if you stitch the tear by interrupted mattress sutures by taking the whole thickness of the cervix 2 centimeters above the apex, which are material 1-0 chromic catgut or 2-0 vicryl, whatever is the patient, the obstetrician's choice. This prevents the rolling of the edges and is a better choice to do the suturing. So any cervical tear extending beyond the vaginal vault warrants a laparotomy. Small non-bleeding laceration need not to be sutured. Any bleeding which is longer than 2 centimeters should be sutured with the absorbable suture on a tapered needle. A suitable method of suturing is both the edges, as I am reinforcing it again. It should be held with a hemostat, bring down into view, properly view it, and then only suture. There are several lacerations which can be present, which can be left for observation. Every laceration need not be sutured. Sometimes the good packing and adequate hemostasis or ring forceps place, it is the well job done. You don't no need to poke the needle every time. These cervical lacerations of the vaginal wall crustaceans sometimes continue to ooze despite of treatment as detailed above, and these can lead to hematomas which may be amenable to selective arterial embolization in a later stage if it is not stopping. So here I would like to highlight the learning points. A cervical injury, which is avulsion type, is a rare phenomena, but wherever it is encountered, careful attention should be paid to the upper vaginal part, as the extensions may also go into the adjacent structures, including the intra-abdominal organs such as uterus, broad ligament, and blood supply that runs through these structures. So we can be having a broad ligament hematoma, so we should not ignore. High examination is very, very important. A vaginal laceration that extends capillary may indicate such extensions. Conservative reparative management, such as rather than excisional treatments, appear to be a viable option in some cases, which is especially important in women who wish to retain the fertility, as Dr. Verma Madam highlighted very nicely. Due to the vascular nature of reproductive organs, even significant injury will not necessarily cause necrosis. This is a good thing which is very important. So even a part of the cervix which is attached, blood supplies are maintained, and sometimes this partial avulsions, if stitched properly, have a good cervix, and later on when we examine, it actually amounts to like we had never operated before. So repair and careful observation during recovery are feasible in some cases. We should not forget the principle of traditional medicine, that using frequent bath and seed bath close to delivery, soft massage with some types of oil, especially coconut oil, camomile oil, which we prefer mostly. This positive effect can be potentially observable in antepartum massage. Refer to the regular massage of the perineal body and the lower vagina in last month of pregnancy, which increases the circulation, decreases the birth trauma also. And it is believed that beneficial effect is because there is improved elasticity of the vaginal tissues and increased blood flow, improved perineal relaxation is got with this. So it is noteworthy that most prominent benefit of water birth in recent studies has been expressed by reducing the perineal trauma and the need of episiotomy. How to prevent this cervical tear and how to anticipate that? It is very important to do serial digital examinations of the cervical response during the induction of labor. Particular attention should be paid to the characteristics and modification of the external os. Upon completion of cervical effacement and in the presence of significant uterine contractility, if repetitive finding of rigid external os is there, it is an alarming sign. We should be prepared that this lady is going to head into a cervical tear. So this is a window period, regardless of etiology of this complication, could be prevented by performing a cesarean section upon recognizing of the pathologic significance of the external os rigidity, which is not yielding in spite of good uterine contractility. So what is the recommendation I would prefer to do in the antenatal? That serial prenatal ultrasound is very, very important. A transvaginal study of the cervix is a good option, where the cervical length is a good thing, which we should always do from the first trimester, starting from 10 weeks to the, say, 34 weeks also, with consideration of cervical cerclage and elective cesarean delivery to reduce the risk of preterm birth and recurrence of annular cervical tear, especially where we have got a history of recurrent DNCs or multiple cervical procedures in these patients. So to summarize, bilateral cervical tears are those which end up as ectropions. Remember, extensive cervical sphincter damage may lead to preterm deliveries, especially first and second trimester habitual painless abortions are reported due to this, and clear documentation is what is very, very important. A proactive approach, early intervention are vital signs to obtain a good outcome when we talk about the cervical tear. And here, before saying a good thank you for the kind attention, I would like to say that we all can be extraordinary, doctor, but I want to tell everybody that you are an extraordinary human being, because we are taking care of our patients as we are dealing with our own family members. That is what I was taught by my teachers, that always place the patient before you. think that you are lying into her position, and never lose to go for a small things also, never neglect, so that you have a better outcome. So I'm very thankful to my teachers, the ISOPARB committee, for giving me this honor to share the dais with dignitaries like Verma Madam, my own professor. I feel very great talking about cervical tear, because she was the one who gave me my first cervical answer class suture. So I'm here, madam, in front of you, feeling really very obliged. And thank you, Ranjana ma'am, Amita di, ISOPARB team, for having me here. Thank you so much from the core of my heart.
Wonderful, Dr. Archana. It was indeed a great talk. At the outset, I would like to thank Ranjana ma'am and Dr. Amita for giving me the opportunity. And my regards to Manju Verma ma'am, Dr. Parag, and Dr. Pai, and Dr. Sadhna ma'am, and all the dignitaries on the dais, the senior chairpersons, and the wonderful speakers we got a chance to listen to. So, Archana, you did a great job, and like you very well pointed out the risk factors. And yes, of course, we should have a high index of suspicion, and we should, while we are conducting a normal delivery. And as you rightly said, that digital examination is a good thing to monitor the dilatation. But I would also point out that there are certain over-enthusiastic birth attendants who keep on pushing the cervix also. They keep on like, they don't only like keep on massaging the perineum. They
stretching,
they keep on pushing the cervix and try to stretch it over the presenting part and mainly the fetal head. So that should be discouraged in such patients. And while we are putting an encerclage to any patient, we should tell her that if she has even the mildest pain or slightest bleeding, she should report to the hospital, because the worst kind of tears, the bucket handle and the annular kind of tears, which you said, are more likely to occur when the cerclage is there in situ and the patient starts having pain. We have witnessed that. And one more thing I would like to stress upon, that it happened to me a month back only, that a patient was delivered at the periphery. She was packed there was pressure on the cervix, and when I pulled out the pack, there was no bleeding at all, and she was fine. We gave her blood transfusion and everything, and she was okay. And after 48 hours, I sent her away. And again, she came back after a week or so, and she was bleeding heavily. She was in shock. And then there was a tear which had started bleeding again, probably because of the necrosis or infection or something like that. So we need to, even the patient, if the patient has been sent to us for PPH and at that moment she is not bleeding, then also we should inspect the cervix.
Exactly.
That is it has happened with me. It was my fault, okay, but I understand that, but yeah, it has happened. So that is all. And
sometimes we just take it for granted that because of the packing, the bleeding has stopped.
And
so
it will,
all is fine.
It will be like that.
Yeah,
it will be
remain like that.
I think that is why the minor details should never be missed. That is what and taught.
And so we need to be careful. Even if the bleeding has stopped, we need to inspect everything before sending.
I've got a feeling that Dr. Verma wants to say something.
Yes, ma'am. Yes, ma'am. Definitely.
I would like to congratulate again, Archana, everyone, for the wonderful session that we had today. For the cervical tear, I would like to only say one thing here is that you don't start stitching from the apex. Start stitching from the below. Take stay sutures. When you give a pressure over the stay sutures, you can easily find out where the apex is done. And the last distance should be at least 0.5 to 1 centimeter above the apex. So this is the only way that you start stitching from the back so that you can reach the apex easily.
But if you are seeing the apex clearly, then there is no harm in stitching from there.
Yes, true.
If it's not extended very much, then sometimes it's good to start at the top only.
And it's a good idea, ma'am, if you ask someone to push the uterus from above, which Archana pointed out. Yes.
Yeah.
A very, very nice points that she has brought out.
Yeah.
Thank you, ma'am. Thank you so much. Thank you.
So I think, Chitra, you can conclude.
Yes, ma'am. I can't find any questions. I think everybody has explained it so well. There are no queries. So we directly move to vote of
The
thanks.
queries were discussed actually.
Yeah, it is.
Along with each topic.
Yes, so, on behalf of ISOPARB Prayagraj, I thank each and everyone on board today for this webinar. But my first and foremost thanks goes to Honorable Chief Guest Dr. Hrishikesh Pai sir for his gracious presence, valuable advices, and pearls of wisdom, and very interesting statistics which he put forward, and about whatever he talked about NCD survey, some very important things. And we all know that the concept of scientific Sangam is brainchild of our founder president, Dr. Ranjana Khanna ma'am. Thank you so much, ma'am, for such very thoughtfully chosen topics. And now I extend my sincere thanks to all the learned speakers for their brilliant deliberations, covering almost all aspects of trauma during labor, beginning with Dr. Amita Umesh Shah, who emphasized the importance of prevention of perineal tear with very good revision of pelvic anatomy. And Dr. Parag Biniwale, who explained that if perineal tear happens somehow, then how to manage it, and the importance of proper management of anal sphincter injury with good technique and the documentation to prevent the morbidity and litigations. Thank you so much, respected Professor Manju Verma ma'am, for such a comprehensive talk on rupture of unscarred uterus, and beautifully explained that how important it is to have high suspicion of and the importance of early diagnosis of, as the mortality is higher in a rupture of unscarred uterus. So that was very, very important. Thank you so much, ma'am. Whenever I listen to ma'am, I feel like that MBBS student. It's always so nice.
Today the topics which I chose were like that only.
Like that only.
It's like a nostalgia went to the labor.
Yeah.
It
brought us back to the house job days, you know, when we were in the labor room.
Directly reached in that period. So thank you so much, ma'am. And thank you so much, Dr. Ranjana, for very crisp and clear presentation.
Yeah.
Beautifully explained. My heartfelt thanks to all the chairpersons, Dr. Ranjana Khanna ma'am, Dr. Satya Gupta ma'am, Dr. Manisha Gupta, Dr. Amrita Chepriya, Dr. Preeti Niranjan, Dr. Aruna Chaparia, Dr. Garima Trivedi, and Dr. Babita Shukla for your expert opinions and sharing your immense knowledge with us. Special thanks to office bearers of Baroda and Gorakhpur Society for their support, and also of our Allahabad Society. We are very grateful to ICOG office for granting us 2 ICOG points, and my sincere thanks, and with love I thank organizing secretary of this webinar, Dr. Amita Tripathi, for meticulously planning even the smallest detail regarding this webinar and implementing it perfectly. So, and thanks to my co-convener, Dr. Abhilasha and Dr. Parul, for conducting all the sessions so seamlessly. And a big thank you to all the attendees who made this event interactive and interesting. And last but not the least, I thank our academic partner, Jagsonpal Pharma, for their constant support in all our scientific sangams. So thank you so much. Thanks, everyone. And at the end, I extend a very, very warm welcome, and I invite all of you to our conference on obstetric dilemma, that is on 6th and 7th of August. And we'll be looking forward to meet everyone. I welcome each and everyone, and looking forward for you all to Prayagraj.
Thank you.
Thank you, ma'am. Thank you so much.
Bye.